Thank you so much, Shannon. That was wonderful. So now we are going to have a brief question and answer period. I invite you to think of any questions, or if anything hits you about any of these presentations, these talks. Feel free to offer. I guess just yell out. Do we have a mic that we're running around with? Okay, I think we can. Oh, we do have a mic. Okay, so I actually have a few that I've written down and listening to these wonderful presentations, and sort of in no order I can maybe bring up a question or two. I was struck, James, by the fact that the changes in the vagina are actually quite reversible and with treatment. And so it occurred to me, does that mean that if you need treatment and you get treatment, you're on treatment for the rest of your life, for the most part?
So this turns out to be a very good comment and question. And I'd like to have you go back to my comments about lactation, because, lactation is typically a temporary phase in a woman's life. Something like less than 4 years or before he or she gets teeth is usually the duration of lactation. And afterwards, the vulva and vagina go back to their normal pre-menopausal, pre-lactational phase. So this also is something that can happen after menopause with proper treatment. But I think your comment that most women, or many women, require long-standing treatment in order to maintain those healthy tissues is totally true. Unfortunately, many women self-treat, symptoms get better, and then they stop until symptoms get worse again, and then they self-treat. And this actual cycle of on and off is probably worse than continued treatment, because what happens in the middle is there's pain, there's reflex pain avoidance, there's the impact that we heard from everybody on relationships, and in addition there's colonization of the vagina and urethra with pathogens leading to urinary tract infection. So yes, the vagina has a very good memory, and yes, it needs to be constantly supported after menopause.
I'd like to make a comment. The women, when they ask me about statins or blood pressure medicine or vaginal atrophy treatment, this is a question not just about this. They say, do I have to take this forever once I start? It's sort of like they cross some bridge that gets bombed once they cross to the other side and they can never go back. It's like, what if I start? I can't stop. Like, there's, so what I say to people is, well, what you need to do is look at the perceived need now compared to your perceived concerns about the treatment, and just go forward. Nobody's bombing the bridge. The relationship will change, your perceptions about yourself will change. And that's one point. The second point is that when people, I'm an internist, so I see the patients who come back to me after they see Dr. Simon and they're all enthusiastic, and a year or two later they've stopped. And I say, well, why did you stop? And, then they'll sheepishly tell me, well, I was worried about the estrogen. I don't want to get breast cancer. I heard that if you take it for 3, there's tons of misinformation. And I think certainly Dr. Simon constantly re-educates patients, but many gynecologists don't. They assume once it's done, it's over. And that women, the fears and anxieties start to creep in as people have been on things for a while. And that's when the re-education becomes really important. And ongoing reinforcement about what we know about long-term use is very important for any product that we're going to use. You can't reverse vaginal changes without a medication. So we have to constantly re-educate and help patients weigh the perceived needs and the perceived benefits versus their perceived risks.
I've got the mic. Are you ready? Okay, so I'm Tamara Pingus. I'm a sex therapist in private practice in DC. And what I was really struck by was the focus on intercourse as the only kind of sex that you guys really talked about. Maybe I missed something, but it seemed like we're really focused on the vagina. I didn't hear as much about the clitoris. And I'm wondering if we know about what happens to the clitoris during menopause and how sensitive it is, and would focusing on, say, oral sex or other kinds of sex be helpful in treating some of the vaginal atrophy to sort of focus there before we go into just trying to move right to intercourse. So I was wondering if you had thoughts on that.
Well, thank you. Apparently I did not make the point well enough, but I do think that intercourse is only one small aspect of sexuality at any age. And that, as I talked about orgasm, it is not a reliable way for women to reach orgasm. So using all kinds of sexuality and to let women know that that's normal, because a lot of times women come in and say, you know, if I'm not having an orgasm with intercourse, and remember, not all of your patients or women are heterosexual anyway, so penetration may be the more accurate term. But I don't have orgasm with any kind of penetration. Is there something wrong with me? My partner, my husband, says all his other partners used to be orgasmic with intercourse. I don't think that's accurate. And it's about educating women that there's all kinds of normal, and that is true for pre- and postmenopausal women. I'll let Jim talk about the changes to the vagina with, to the clitoris with loss of estrogen, but that too is not, it does not escape the loss of estrogen.
I'll just add one piece. I often have clients focus on what we call outer course, which might be referred to as sensate focus in other forms in practice. And that's really using sensual touch and massage and also other primal intimacy, such as kissing or different types of touch, into their sexual play with a partner, as well as something we call vibrator priming. So if she is dealing with atrophy, during that time to use vibrator priming of the clitoral area and vulvar tissues to really stimulate blood flow, as well as using some mindfulness, and relaxation to really help prime all of her vulvar tissues. So there are definitely a lot of different forms that we focus on.
Excellent.
Sure. I was asked if I wanted to say something. I always want to say something. But the other thing that I think we really can emphasize further is that women need education about changes in their body with age. And many women have not needed to use a vibrator because they just get stimulated with touch or with oral stimulation or just with anything, anything that happens. And one of the biggest things to say to women that are peri and postmenopausal is that you need more stimulation with age, particularly of the clitoris. And have they thought about whether they're interested in using a vibrator? And there's a lot of doctors who don't want to recommend that to patients. They get nervous. So thank God we have sex therapists, but I think training our doctors that this is can be a medical piece of advice.
There's also a new study, actually it's now a year old, showing that 51% of American women use a vibrator. So it is very normalizing for women. When I give them that statistic, they'll say, oh, you mean I'm not some, sort of...
That's the other side of it.
Out of the ordinary, and it's 51%, and they feel much better about that.
So I would just say that genital sensitivity, that's all parts, and genital blood flow, that's all parts, are hormone sensitive. And whether that's a real, natural, bioidentical type hormone or a synthetic hormone or an agent that fakes those receptors into thinking it's a hormone, it's all the same to the tissue.
Actually, I was going to ask you a question. I'm Florence Hazeltine. I was going to ask Dr. Tasimas a question. When I started out in practice in OBGYN, we did breast surgery. And many of our patients, we don't do it anymore, but gynecologists did it then. And one of the things that we found was that most of them stopped any sexual activity. And for one thing, many of them had, at that time, prophylactically had their ovaries removed. Now we do it in certain other cases. So they were abruptly not only lost their breasts, they were thrown immediately into menopause. And I wonder how, with the new surgeries and the changes in perspective, that's occurred. And it's sort of a general medical question, because we didn't deal with much about medical problems women over 50 get just because we get older. So anyway, I'm sorry I'm going off the panel, but I wanted to ask her specifically because she's just came down as head of breast surgery here.
Do you want to come up here, or?
Yeah, I'll sit there.
Okay.
Thank Thank you, Florence. Can you hear? So I am the head of breast cancer surgery at Georgetown, so I'm new to the area, so I haven't met Dr. Simon before. But it's really a multifactorial question, because when patients are diagnosed with breast cancer, there's so many factors that go into play. It's both physical and it's mental. So the physical part is a lot of the patients undergo chemotherapy, and they suffer from vaginal dryness and decreased libido. And for most of these patients, there's a recovery. But there's also the mental aspect where there's severe depression, and there's also body transforming surgery. And it's not like removing an ovary. Removing a breast is a whole nother can of worms. The aesthetic results from breast reconstruction have improved dramatically over the last 10 years. And I wish I had brought some pictures to show you, but some of these women, you can't even tell that they've had a mastectomy. The scars are really hidden in the bra line, and the implants have changed with shape. They're more natural, they're softer looking. And a lot of the women, they can't even tell from looking in the mirror that they've had a mastectomy, but they can feel it because they've lost sensation to their skin and they've lost innervation to their nipples. So psychologically, there's so many things that impact them, from the intimacy and sexual function after having basically breast cancer surgery. And I was actually, that leads to my question that I was going to ask you, Dr. Kinsberg. How do you counsel patients who have had breast cancer surgery maybe prior to 10 years back, when they either did not undergo reconstruction or the reconstruction was less favorable?
Well, thank you. And thank you. Welcome. Washington is now lucky to have you, so thank you. Well, two things. One is actually Dr. Parrish and I just came back from a training session at Ishwish where we're training generalists how to help their patients after cancer. And one of the topics they came up was helping patients talk to their partners about things like touch. For example, if one partner's continuing to touch the breast that has no sensation, how do you guide him or her to touch the other breast or not do something irritating? So number one is education. Number two is a lot of times for women, they assume they're no longer sexual or attractive, and then their partner, who has been protective of them, is not initiating sex, and then that confirms her belief that she's no longer attractive because he or she doesn't initiate. She says, see, I knew it. And it's about educating them about resuming sexuality. Third is the effects of chemotherapy, which is tremendous. You know, the vaginal stenosis and changes on sudden menopause. So it's, you know, head to toe, teaching them about body image, their sensuality, how to, you know, address the sudden menopause, because many of these women are premenopausal. You know, there is a difference between a postmenopausal woman who's already been estrogen deprived versus somebody who suddenly loses estrogen and androgens. So I've worked with our breast cancer, the oncologists and the surgeons for many years. I love having that interplay because the interdisciplinary approach is magnificent. Somebody like you who already knows the psychological aspects will already educate. I have to say, you do half the work. By letting the patient know this probably may impact your sexual function, I'm available to talk to you about it. Number one, tells your patient she's going to survive, and number two, she's entitled to her quality of life and sexuality back, which is huge, and then referring them to somebody who can then make sure that it stays intact or resolves it. You become so important to them and their sexuality. It is such a dynamic interplay. So thank you for the question. And sexuality and cancer is a huge issue, and we probably could do a whole nother session on that too.
So I'd just like to say a couple of other things. As a board member of the American Society of Breast Diseases, we do courses in oncoplastic surgery, which are commonly missed in general surgery training. These are kind of combined plastic surgery and oncology breast cancer surgeries that can result in really extraordinary differences in the cosmetic and to some degree a functional outcome of the breast after cancer surgery. I also want to say that it has become the norm to treat ER-positive breast cancer these days with aromatase inhibitors rather than tamoxifen, even though the mortality differences are non-existent. But those two therapies have vastly different effects on sexual functioning, both above the neck and below the navel. And so I think there may be advantages in certain individuals who are profoundly affected by aromatase inhibitor therapy that they may have an option, although they may not have been given an option, to use tamoxifen instead. And they may have a much better quality of life under those circumstances.
Do you mind just saying another word or two about that? I think that's a really important point. You're saying aromatase inhibitors and tamoxifen have vastly different effects on on the organ.
They have differences in effects on cognitive function, mood, sexual interest, arousal, orgasm, vaginal atrophy, and it's vulvar and vaginal atrophy. I mean, it goes on and on and on. Now, that doesn't mean that one might not be better than the other in a particular case, but frequently there's little discussion as to what's best for Mrs. Smith, and frequently little discussion about the sexual effects, whether they're cognitive, emotional, etc., or vulvar and vaginal after the fact. You know, you're going to be on aromatase inhibitor for 5 years, and that's like, that's it. It's done. It's not changeable, but that's really not usually the case.
There's also the issue of whether you would treat a breast cancer survivor with local estrogen or aspina or not, because some women are absolutely petrified of anything estrogen, and then it's weighing again the quality of life issue, their true risk for using a local estrogen versus what they hear about estrogens.
Sexual Health Association. I'm curious if, given this kind of long list and increasing long list of products that are available, is there anything that teases out which are more effective than others, or are some better for some conditions? There's Aspina from just February, and Vagifem. I mean, there's a kind of a long list of them, and it's hard to know what to think about them. Are they specifically some better for individual women responding differently to each, or are some we just know the data show are more effective than others?
So I kind of got stuck with treatment, like for one 90-second spot on all the treatments. What I wanted to re-emphasize, which maybe I didn't do effectively enough, is that there are multiple options for most women, but the most overused option is no treatment. And while there may be certain individuals that will respond best only to a single treatment, or may need specialized therapy, or may need testosterone local therapy in addition to estrogen or Aspina or something, I don't want to emphasize the differences in the treatments. They were all the FDA-approved treatments had the same basic benchmarks. It's a little over exaggeration, but basic benchmarks, and there are no head-to-head studies that I'm aware of. So without those, it's difficult to know if one's fundamentally better than the other, and no treatment is still the market leader.
But I think you said more than that. Fortunately, there are numerous local estrogen treatments, and there's 2 oral therapies available for women, and Aspina is one of them for vaginal atrophy symptoms. There's sort of one in each type, right? There's a pill, there's a vaginal tablet, there's a vaginal ring, there's a couple of creams. So you can start there. Is like what do they prefer? Do they want to put something in for 3 months? Do they want to use something twice a week? Do they want to take a pill every day? And I find myself and many of my colleagues find that's a good place to start. But I just want to back this up one more time. I think breast cancer survivors is such an important discussion, and what's safe to use, and just the fact that it's even being considered in the mix as a priority. That's as important as not the breast cancer not coming back, is just the first step. The other thing is even back further is that in deciding about treatments when women don't have breast cancer, that is one of the most important fears or confusions that drives decision making. So if you're going to address medical treatment for vaginal atrophy symptoms and sexuality, you have to address that head on. What do you know about this impact on breast cancer? What are your concerns about it? What information can I give you? And this is an important piece for re-education. It's very poorly done because physicians aren't confused and ill-informed.
And Sharon, one of the other issues, I think, for patients who get a local estrogen, for example, or even Osphena, is that the insert has exactly the same warnings for local estrogen and Osphena as it does for systemic. And so women will come in and you will say, well, I had this conversation and you said this was local, but look at these risks. And they're scared to death. So you need to talk to them about what they're going to be reading when they come back from the pharmacy.
And recently, actually, we tried that, and the patient's like, okay, I don't want anything. And we're like, no. It's not to get you to stop because I told you about the black box warning. It's to get you to know what to do when you see it, and you have to go that far.
So hi, I'm Elena Florman. I'm with the Association of Reproductive Health Professionals. And I know this point came up a lot in all of the presentations, but sort of this idea of interprofessional teamwork and how we have to not only combat the patient barrier to dialogue, but also the provider barrier. So my question is, and perhaps it's for the whole room, is how can we really rally these providers to initiate this discussion? I know that we do continuing medical education and discussions like this, but how can we really drive the point that sexual health and reproductive health and all this is really meeting primary care in the clinic and to really initiate that conversation?
So I want to jump in here since I'm the local guy and because I've figured out a way to do it. So the biggest problem today is money. It's all about the money. Now, the patient sometimes gets lost in the fact that it's all about the money. And women have some blame here. They come to the gynecologist, frequently to the primary care doctor once a year, and they want everything taken care of. So the insurance industry helped us a little bit, for once. They said a woman can't be sick and well on the same day, otherwise you can't treat her wellness or you can't treat her sickness. So you can't have a well woman visit. That's that annual exam that everybody wants to get everything done with. You can't have it and have a problem. So you can't have a problem visit, be sick, and be well on the same day. So whether it's the insurance company or the doctor or the patient, they can be educated that they need to come back for the problem. And if we follow Sharon, all of us actually, if you follow our advice and tell the practitioners, listen, there's more money if you do her annual exam and say, look, you really have a problem. I really have solutions. I haven't blocked out time today to adequately address your symptoms. It's an important problem. I want to take care of this, and we can work through this together. Make another appointment. Ka-ching. And the insurance pays for that. So there is a way to leverage the situation that we're in, the problems of time management and reimbursement, for the benefit of the patient if you take that attitude. Otherwise, it's, oh, by the way, he or she, the practitioner, has got his or her hand on the doorknob halfway out the door because he blocked out time for an annual well woman visit and doesn't have time for all of this other extraneous stuff.
Well, also, clinicians are uncomfortable talking about sex. Patients are uncomfortable. Clinicians really are. They're uncomfortable for two reasons. We don't educate them in medical school or nurse practitioner school. We just don't get them comfortable saying the word clitoris or cunnilingus. They just can't do it without turning red.
Oh, my goodness, I can't spell it either.
Yeah. So they're uncomfortable, and so we need to get them more comfortable to practice, to let them know that patients expect it. It is part of what they need. We talk about the fact that most clinicians are afraid, if I open that door, talk about a visit, there goes 20 minutes. That if I open the door about sex, I will never get them out of my office, and that's not true. And if you ask an open-ended question, you will get the response back very shortly, and I ask them to try it. They don't have to continue if I'm wrong, but if they do and it only takes a minute, they're more likely to do it again. And the third issue is they have no pharmacologic options to offer. So whereas urologists and primary care docs for men feel more comfortable asking about ED now because they can offer a treatment, we can offer treatments for vulvovaginal atrophy, but we have nothing for the most prevalent sexual disorder, which is hypoactive sexual desire disorder. And so clinicians are afraid to open the door. If they don't have a clinician in their area, they can refer to a sex therapist, for example. And we try to educate them about the alternative treatments besides medical, but they have nothing in their medicine cabinet that they can offer. And I think that's a real barrier.
And I just want to comment, since I work in a clinic that really has been a first of its kind integrating, it's having disciplines come together and work together. Organizations like ISWISH and ASEC, they're full of all types of different providers, so you can go and get education on what other professionals do. And working with an MD, I wasn't as familiar with all of the different pharmacological or physiological interventions. So really, as providers, educating ourselves and getting training. We now offer a training where we teach our model to different clinics and different centers. So we're starting to make that change by creating better education for providers.
So I'm going to say something else. Although we all advocated for the importance of having FDA-approved products for the other types of sexual problems that women experience, we have many things to offer patients with sexual problems. I can list at least 50 things that I can offer besides pharmacological therapy for dyspareunia for my patients with sexual dysfunction. And I think it's a myth, and I think it's a cop-out on the part of the clinician to say, I have nothing to offer patients. It's absurd. We could treat depression, we could deal with alcohol, we could deal with prescription opioid use, we could offer lubricants, we could discuss contraception and the best choices, we could stop antihistamine. There's a million suggestions that I could make even off the top of my head, and I think of a patient with every sentence here, every phrase. So it's really about education across all levels of the healthcare providers, even the nurses. But she was mentioning talk to the nurse. I thought about it for a second when you said that. What would my nurses do in my big inner city clinic? But we could educate them to respond, especially if they knew why I'm seeing patients on a particular day.
We have a question?
Yeah, this is a great segue because my name's Deb Calgren. I'm with Office of Women's Health, FDA. I was getting ready to have surgery, and the nurse was standing there talking to me. Oh, what do you do? Da da da. And when I told her, as I'm being wheeled off, she said, I really want to talk to you about hormone therapy. And I guess because working with the FDA, we obviously have an inside track, but we exhibit quite a bit. And I can tell you at the exhibits where there's a lot of consumers, the number of women that will come up, and after everyone has kind of walked away, they'll come up and they'll say, what can you tell me? Is there any, these things, do they really cause cancer or don't they? I was talking to Chris earlier. I've had women come up to me and say, well, I had such severe vaginal atrophy that I couldn't sit down anymore, or I had difficulty sitting, so I finally had to use something. Or I'm a breast cancer survivor and I've had this issue and it was a quality of life. I finally had to take something. So somewhere out there the message isn't getting to them that this isn't life or death, that there is something that they can do, but they want something, but they're confused and there's a lot of misinformation.
So one of the things that the audience may not fully appreciate is that for many different classes of drugs, we have class labeling. And for estrogen-containing drugs, or drugs that act like estrogen, we have a certain amount of labeling for all the products that's class labeling. And so, for example, the class labeling for estrogen and drugs that act like estrogen has a large amount of information about the Women's Health Initiative, about systemic effects of estrogen, even if those estrogens are largely local, or even if there's little or no relationship between that particular drug and the Women's Health Initiative. But this is the kind of world we live in where the boundary lines between data may be a little more obscure than we would like, and where everyone's concerned about risk and we have to kind of tease those boundaries apart for the individual woman and for the individual drug, which sometimes can be very difficult.
We have about 5 minutes. Any other questions? I have one if we don't have any from the floor. I think it was you, Sharon, that might have mentioned 70% of women have not discussed vaginal atrophy with their HCP, with their healthcare providers. What if you don't have vaginal? When should you be bringing up the possibility that you might have vaginal atrophy? Let's say you don't have pain. Maybe you have the beginning of atrophy, and how often should you be bringing this up in your well women's visit? Let's say.
Well, I think we've probably driven the point home that although symptomatic vulvovaginal atrophy of the urogenital symptoms and sexual symptoms are common, and at least half of women have been surveyed, there are asymptomatic changes and they'll progress. And I think women need to be given informed consent, in a sense, about what will happen to their bodies. And, do they want to wait till they have symptoms or not? And we have had, in our societies and in our meetings, we've had some discussions about treating the asymptomatic vagina and vulva. That's an interesting question for Dr. Simon. The other thing is that sexuality isn't just about the vulvovaginal atrophy. And I think every woman has questions about her sexual function and her sexuality at least once a year. So I think we should activate patients, like Dr. Chavez said, to think about their questions that they have. Now, there's a lot of discussion about how often a well woman visit should happen, and that's probably a whole other conversation. But whenever you get there and you have the opportunity to talk about your wellness and you have questions, you should bring them up. That's what I would tell patients. And they'll what I teach is they'll either handle it, they'll reschedule, or they'll refer. And that's what a competent clinician should do.
Do you have a question over here?
Yes.
Yes.
Yes. My name is Amy Benavides, and about, 13 years of trying to figure out what was going on myself until I found out what was really going on. So I guess when I was about 13 years ago, I started having perimenopause, but no one believed me because I was in my mid-30s, until I finally had hot flashes 10 years later. So I was put on everything from thyroid medicine to all kinds of crazy things. Gone through doctor to doctor, but finally I found somebody, and now she just cut down to 2 days a week at Johns Hopkins because she's about to retire. So I finally found somebody who seems to have the knowledge. But my question is, and I was doing research, I couldn't find information, and you talk a lot about education. Is there a movement to do more education within the schools, or is this more after doctors are out in the field? And how do you get really good education to the average patient? Because when you go online, it's just people asking each other questions. I've got this, I've got that. Oh, I've had it too. If you get an answer, can you let me know? So I just was kind of like, what do you mean when you say education? What can be done?
Well, I think there's a large movement to increase education to all kinds of healthcare professionals about sexual medicine, sexual health. ISHWISH certainly is a proponent of that. The North American Menopause Society is a huge proponent of that. There was just a publication in the Journal of Sexual Medicine on a consensus conference about education in medical schools, because that has seen, I think Dr. Chavez talked about the decline in how many hours are devoted, because there's so many other things that sex keeps getting, smaller and smaller. And I'm the one that's in charge of the sexual medicine in our medical school, so I'm always fighting for time. So there is a movement to try to have a resurgence of education, and that will then generalize out to nurse practitioner and PA schools as well. And then at the postgraduate level, when they're out in practice and they realize, oh my God, I didn't get that in medical school, and there is actually a survey showing that most medical school graduates wished they had had more sexual medicine education in medical school. Now we can give it to them when they are in the trenches and need it.
I just want to comment, too, that women's sexual health really is a new field. It's only been since the early 90s that a lot of research has been done and that we've started to really look at female sexual dysfunction. So I know myself and some other sex therapists are actually going now to speak at medical schools and talk about the importance of sexual counseling and therapy and how we can help educate doctors. So I think there are definitely a lot of movements, but it is still just a new and emerging field.
I think women need to advocate for themselves. The quote that Cheryl showed from our suffrage movement really old, and I'd love to see women advocating more for themselves, and whether that means being tougher in the bedroom or tougher in the courtroom or tougher in the ballroom. No pun intended. It means being more strongly involved in their own health, and in particular in their own sexual health.
That's a great note to leave it. Did you want to say something, Phyllis?
Bladder cancer, has left, but it concerned me because I've spoken to a number of people about women and bladder cancer, and one of the symptoms is bleeding, and that was listed as a symptom there. So I think there's another reason for doctors to be asking postmenopausal women, maybe even not postmenopausal, about bleeding, because it may not be as important as this conversation is. It may be about something else. And one of the things that happens with bladder cancer is that while it disproportionately affects men, women get diagnosed later and have more mortality because they don't recognize it as something out of the ordinary. So I know that sort of changes the conversation a little bit, and I apologize for that, but I do think that's another important reason to make that a question when women come in to talk about sexual issues.
You know, I think we're ending, but I do want to say that I've had number of patients who have not had pain that was caused by sexual function events and ended up having other pathologies, and so they're assuming that it's due to just because sex bleeds, right? And so I think that's important.
And I think the double standard, we now know that ED is often an early warning sign for cardiovascular disease, so physicians are more, or healthcare providers are more apt to ask. The same thing about teaching them that sexual problems may be an early sign of other problems might enhance their willingness to ask about them.
Yeah, so I thank you. So I do think there are other reasons, other than all the conversations that we've had that are as important. So I want to thank you all for coming this afternoon. I hope that you've learned something personally and also professionally. The point of inviting those of you whom we did invite was because most, if not all of you, represent organizations that deal with women in some capacity, a medical specialty society or advocacy groups. And so what we're hoping is that you can take this information and disseminate it through your constituencies. So this doesn't just stay in this room and enhance your knowledge, but gets the information out to the people that you represent and work with. We will have a webinar. We have, Michael, would you say what we're going to have?
We're going to post videos of the presentations today on our website. Give us a couple weeks to get those posted, but everything here will be posted on our website.
So we will send you information if you want a link to our website. We'll have a summary of on this on our website as well. Free to take it and use it. So the idea really is to disseminate this information and as broadly as possible to help your constituencies. So I hope that you'll do that. I want to thank you all. You were terrific. Thank you so much. And Dr. Kingsburg, as always, for your keynote speaker. We really appreciate it. And I also want to take this opportunity to thank Shionogi for their generous support of the Society and our entire sexual health program work. So if you need, I think it was terrific. There is in your folder places where you can go for more information, or you can educate your constituencies to go for more information. I hope you'll use that. Thank you very much again for coming. We appreciate it.